Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. New York is the 13th state to authorize some form of physician-assisted dying with the passage of the Medical Aid in Dying Act, which takes effect August 5th. To understand more about this new law, I'm talking with Edward McArdle. He's a lawyer and an assistant professor of bioethics and humanities at Upstate, where he serves as an ethics consultant. Welcome to The Informed Patient, Mr. McArdle.
Thank you. Glad to be here.
This is a bill that was first introduced 10 years ago, so it's gone through a lot of changes over the years before it was passed. In general, can you tell us what this bill allows and the impact it may have on medical care in New York State?
I served on a New York State Bar Association task force that looked into this bill and made some recommendations regarding it, recommended that the legislature pass it. It provides a legal path for individuals who are terminally ill and mentally competent to ask a physician to provide them with a prescription of medication that would hasten their death. And the key points to this are that it's patient-driven. The patient must have the capacity to make the decision to ask for assistance. They need to have the physical ability to self-administer the medication, and they can change their mind at any time.
So who decides if a person is terminal?
That's in the law. That is commonly in New York State law, where we've seen questions about whether a person is terminal or not. It's decided by the attending physician for the person. And in this case, there needs to be a concurring opinion as well. And the definition is that the doctor needs to determine that they are suffering from an incurable and irreversible illness or condition and have 6 months or less to live.
And you said there's medications that can be prescribed. Are they laid out in the law as to which medications, or is that left up to the physician as well?
Well, there's 13 states that have already made medical aid in dying laws, and we also have District of Columbia, and this goes back to the 1990s with Oregon, which was the first state to have a medical aid in dying law. And so we have a lot of history. A lot of physicians in other states have experience with medications. And so there are a couple variations on medication protocols, but it has evolved over the years. So there are certain protocols, and the one that's commonly used these days, which I don't want to get too medical here, but there's a combination of medications that is taken in large quantities. And the goals of that medication is to depress the central nervous system, cause drowsiness, and cause heart arrhythmias. And the medication themselves, whatever the compound is, which includes a pain medication, it also includes medications to dry up secretions. And the goal is in these larger quantities that they would cause an arrhythmia as well as drowsiness that would allow for the person to go to sleep essentially and then suffer a heart arrhythmia and pass away. It's a compounded medication. It's mixed in with about 2 ounces of a liquid, water, or apple juice is commonly used. And the person who's terminally ill would then have to self-administer that medication by, if it's a compounded drink, they would need to drink it, and they need to drink it rather quickly to make sure that it works. And I've understood in about 2 minutes or so, they should ingest that medication entirely.
So they have to be able to swallow and hold a glass, it sounds like?
No, let me just add that these decisions cannot be made by a healthcare agent as well. It needs to be made by the person who also needs to self-administer. There are interesting ways that people have. The key is self-administration. So if someone can't swallow, there are other ways that you can take medication. You can get it through an IV. You can get it through a syringe. You can get it rectally. As long as they are in control of when and whether they want to take the medication, there are other ways of ingesting it, essentially.
Can you talk about the impact medical aid in dying will have on palliative care, and maybe also explain what palliative care is?
Palliative care is an umbrella term for symptom-based medical care under which a patient either directly or through a surrogate decision maker requests the withholding or withdrawal of life-sustaining treatment. The difference with medical aid in dying involves providing a medication as opposed to withholding a life-sustaining treatment. So the intention of the physician and of the patient who requests it is to be provided a medication that will hasten death, as opposed to palliative care, which is about withholding or withdrawing life-sustaining treatment. In both cases, the goal is to relieve suffering, but they are substantively different. I think that we will see medical aid in dying become a part of the work of many palliative care physicians and of many palliative care facilities, but that remains to be seen how that will be implemented in New York. But that's how it's in practice worked in other states that have medical aid in dying laws.
How do you think the New York law compares with other state laws that allow physician-assisted death or suicide?
It's very similar. Every state has substantially adopted the approach that was taken by Oregon. Oregon was the first state to have a medical aid in dying law. It was initially passed by a voter referendum in the 1990s. There was a fair amount of controversy and court cases and things. And after several years, around 1997, it actually became implemented. And so we have close to 30 years of experience with medical aid in dying laws. But every other state has pretty much followed the Oregon approach. Key elements of that are that the patient requesting the medical aid in dying must be competent. They must have the decisional ability to ask. They must be an adult. They must be terminally ill with a prognosis of 6 months or less to live, and they must be able to self-administer the medication. And a couple other things I wanted to add there is to stress that the decisions cannot be made by a surrogate, such as a healthcare proxy, for the patient. And also important is that there's no obligation for physicians or other medical professionals or healthcare facilities to participate in a patient's request for dying. So there is an ability, if you have a moral conviction or religious belief, to opt out as a medical provider or a healthcare facility.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Edward McArdle, a lawyer and assistant professor of bioethics and humanities at Upstate, and our topic is New York's Medical Aid in Dying Act. Let's go through the guardrails that were added to this in order to get it to pass the state legislature. Why was the mandatory 5-day waiting period added?
Well, let me add that in our state, it's an interesting process where laws are passed and the governor has the ability to add additional protections. When that occurs, the legislature then has an ability, if the leaders agree, to then go back in and incorporate those changes, which is what happened here. The 5-day waiting period, I believe, was added by Governor Hochul as part of her review. They sound like guardrails to ensure that this is being done voluntarily, that they're informed sufficiently to know what they're doing, that they are not being coerced by anyone, and that they have the ability to change their mind at any time if they decide that they don't want to proceed. Really, the 5-day waiting period is a chance to provide the patient with a little more time to reflect on their decision. And even with that, there is an exception if the patient is so ill that they might die within that 5-day period, that can be waived.
Why do you think it requires the patient's oral request to be audio or video recorded?
That's an interesting thing. I think New York State's the first state with a medical aid in dying law that's required that. But I would say this was something that Governor Hochul had asked be added. The goal, again, is to protect the patient, to make sure that this is being made by a person who has the capacity to ask and making this request voluntarily and it's not being coerced in any way. So I think that's the primary thing. Again, this is the second request. There's already been a written verbal request. So this is the second chance that the patient can request. And I think it's just another added protection. It really is a protection for everyone, just to show that this was a request by a patient who was in their right mind and was willingly asking for medical aid and dying assistance.
How difficult will it be for patients to get the mandatory mental health evaluation done quickly?
This is another requirement that only New York State has, as I understand. And that, again, was also added by Governor Hochul as a patient protection. So what we basically have now is we have the attending physician and we have a consulting physician who will make a determination whether the patient has capacity. And this is a third opportunity for a mental health professional who would then also have to make that determination. As far as I know from physicians who have been following this law and getting ready to implement it in New York, they don't think this will be a very large impediment. There will be mental health professionals who will be willing to provide assistance. And also, the number of people that are actually going to ask for medical aid in dying is not going to be large. I think the average is about 1 in 300 deaths in other states that have medical aid in dying laws are by people who have requested medical aid in dying and followed through on it. So it doesn't seem like it'll be an impediment really to people obtaining access to medical aid in dying.
Why does the law disqualify anyone who stands to benefit financially, which I assume means family and friends, from serving as witnesses or interpreters?
Again, it's about concern about conflicts of interest, and also that you want to make sure when you look at this that there's no questioning whether when a witness is determining whether this is a voluntary and free request, you don't want someone there who might potentially benefit because it gives the appearance of a conflict. So I think that's just one more of those things. It's been a part of New York law when it comes to other areas. For instance, like with a healthcare proxy, there's certain limitations in who can be a witness there. You want to have impartial witnesses. You don't want anyone who potentially has a motivation to benefit from the person's death to be one of the witnesses. Just another guardrail to ensure that this is a system that is not leading to a coercion of patients.
Does it specify an in-person initial physician evaluation so that these can't be done virtually?
The idea in the law is that there would be an in-person physician evaluation by the attending physician. But as in a lot of places here with requirements, there can be exceptions there. This can be waived and done by telehealth if the attending physician determines that to require it to be done in person would be an extraordinary hardship for the patient, that it would cause undue pain or suffering or extraordinary expense or logistical burden. So when people are really ill, it can be really hard for them to see a doctor. And the other thing is a lot of the expenses related to medically dying are generally not going to be covered by insurance, not going to be covered by Medicare or Medicaid or other governmental programs. So for instance, if someone was so ill that in order for them to go to the doctor, they need an ambulance or an ambulance, there's a fair amount of expense related to that. So the law puts these requirements in that inpatient would be preferable, but does provide opt-outs if it would be an extraordinary hardship for the patient.
Now, speaking of opt-outs, there's a provision for religiously oriented hospice providers can opt out of allowing this. Is that right?
There is. I anticipate people that are familiar with how this law has worked in other states, medical aid and dying laws have worked, as well as contemplating New York, is that there will be religious facilities that will opt out. I don't want to speak for Catholic hospitals, but I think it's likely that a number of them will opt out of offering medical aid and dying. And if they do, they need to have a policy on that. There also has to be an ability to allow for that patient to be transferred to a facility where they could access medical aid and dying. There's also an opt-out provision for individual providers, doctors, and other medical professionals who may have conscience reasons or religious reasons why they do not want to participate in medical aid and dying, and that's perfectly acceptable and understandable and recognized under the law. So yeah, that's a key part of medical aid and dying is it doesn't compel anyone who's a medical professional to participate in it.
Now, New York's medical aid and dying law, this only applies to residents of New York. Is that right?
It does. That's a pretty common requirement. Out of the 13 states that have medical aid and dying laws, I believe there's only 2 that make it available to anyone and doesn't have a requirement that you be a resident of that state. I believe it's Vermont and Oregon that do not have residency requirements. So it's a fairly common requirement for medical aid and dying. We're just following the same path as other states. It is also something that the governor had added in as part of her review, because initially a residency requirement had not been in the law, but that was added in later and was agreed to by the state legislators.
Now, regarding the duties of the attending physicians under the medical aid and dying law, why does the law say that the patients should take the medication with another person present, but that person can't help?
Well, the physician is generally not going to be there. A medical professional is not required to be there and is not expected to be there. The idea of having someone else there is a support to the person. One of the reasons, maybe a primary reason medically, is that these medications need to be taken quickly. And if you're alone and you start taking the medicine and you start getting drowsy and don't complete it, you could potentially have a failed process here. So if you have someone there, they can remind you to keep self-administering the medication. People, family, or friends, they are always a big support. It's recommended that the person have someone there, but it's not required. So as part of the attending physician's requirements, they need to remind the person, suggest that they have someone there, but there's no requirement that they be there.
But this could be a loved one. This could be your spouse or your brother or something.
Absolutely. And probably should be. It should be someone that you're close to, someone that can be supportive of you. And it's not limited to one person. It's just that if you're going to do this, it's better to do it with someone else there just to make sure the process is completed. And it's just a better process all the way around to have someone there that you're close to, a loved one there as part of the dying process.
Well, let me ask you if there's any exceptions, because I know you've said that the patient has to do this on their own without assistance. But there's some diseases, I'm thinking of ALS, where that's not possible in the late stages. Is there any exception for getting assistance in a case where the person doesn't have control of their arm? They can't do this on their own.
There's inventive ways to allow for people that have limited movement, limited swallowing ability to take these medications. That is actually a question that's been raised. If you have someone who is mentally capable, but say has an advanced ALS and they don't have the ability to take it on their own, those people are not able to avail themselves of medical aid in dying. It has been a discussion across the United States about ways of trying to include them. But under current medical aid in dying laws in the United States, those people are not able to take advantage of it. There are ways to potentially rig something up if they have the ability to move a little bit or even below. I'm not sure how that works, but I have heard that there's ways of rigging up the medicine so that if they blow on something, they can then self-administer the medication. So there are people that are going to be unable to take advantage of the law, and that is one group. And another group is people that have advanced dementia who don't have the mental capacity to make that request. They would also not be able to take advantage of this law.
Now, do I understand correctly that the law says this should not be done in a public place? Is it just encouraged or is it forbidden?
It's encouraged. It's part of the discussion that the attending physician has with the patient, which is a very detailed discussion that includes the medication, the risks and the benefits, making sure that they're aware of other treatment options, including palliative care and hospice care, and that they know that they can rescind the request as well. As part of that, they're informed that they should not take the medication in a public place. And I think that's really a matter more of dignity, that this is something just more appropriate to be done in a private area. It's a personal matter. And I think that's the primary reason. It's just a matter of dignity and respect for the patient and for the process.
The law also urges the patient to make sure their family is aware of their plans. Was that controversial to include that?
Not that I'm aware of. These laws are based on the legal right of patients to make their own decisions. They're also based on the ethical principle of promoting patient autonomy and respect for their decisions. So any adult who's competent can make these decisions about who they want to include as part of their healthcare. Who do they want to be involved and informed about their healthcare? When you're ill, family can be very helpful in terms of supporting you. So I don't think that was controversial at all. And again, it doesn't force the patients to include family, but it sort of reminds them this is a difficult process for you. You really should try to get whatever support you can from family or from friends or other people who are familiar and that you're comfortable with.
Was there religious opposition as this worked its way through over the past 10 years?
There has been definitely religious opposition. Key religious groups in New York State and actually across the United States have expressed opposition. It's likely, for instance, that Catholic hospitals will not participate on medical aid in dying. So there is a concern among some healthcare facilities and also among some doctors that they do not want to participate in prescribing a medication that could end up hastening the death of a patient. They are concerned that that would not be consistent with their Hippocratic oath to do no harm. There are other people and providers that would say that you're actually, by helping that person and ending their suffering, you're promoting their autonomy, their rights to make these decisions, and you're also ending suffering, which is a key part of being a physician. So there's been disagreement, and there continues to be disagreement. Overall, polling has shown that physicians by a 2 or 3 to 1 margin, and that the public by similar margins supports medical aid in dying, and that number has increased gradually over many decades. So we're at the point where the majority of people believe medical aid in dying is something that should be an option for patients, but we still have people that have religious convictions or moral convictions about it. And the law respects that and allows them to opt out, both healthcare facilities and also individual medical professionals.
Let me ask you about the health insurance question. Did you say earlier that Medicare won't cover the medications that are needed or the doctor's visits for someone who wants to explore this?
That's right. One of the key issues with medical aid in dying is that it is not covered at this point by health insurance. It's not covered by Medicare or by Medicaid. So the cost of it has to be borne individually by the patient. And there can be some substantial costs. For instance, the physicians may reasonably bill, other medical professionals may reasonably bill for their services, but the cost of the medications can be fairly expensive in the hundreds of dollars or even in the thousands of dollars. So without health insurance, that can be a bar for poorer people to access medical aid in dying. And that's actually what we've seen with data from Oregon, that generally the people that take advantage of and avail themselves of medical aid in dying tend to be wealthier. They tend to be better educated. They tend to be white rather than from marginalized populations.
Will the Medical Aid in Dying Act affect life insurance policies that a person might have?
An excellent question that I had to look up. No, because in the law, it states that on the death certificate, it will show if someone avails themselves of medical aid in dying and then passes away after taking the medication, the death certificate will be filled out to show what the underlying terminal illness was, and we'll use that as the cause of death. So I don't see where it would have any effect on a person's life insurance.
I know you said earlier, like a healthcare proxy can't make this decision for the patient, but can a person make an advanced healthcare directive that says they want assistance in dying? Can they spell it out explicitly? Maybe before they lose their faculties. I'm thinking of like a dementia situation.
It would not help them in terms of the law because a healthcare agent will not have the authority to request medical aid in dying. And that's another one of those concerns with the law, is that, say, if you have a terminal illness of dementia or Alzheimer's, that you need to both have mental capacity to make the request, and you also have to be within 6 months of death, which doesn't always work that way with, say, dementia. So you could know that you're going to have a profound, severe case of Alzheimer's and lose capacity, but that may not occur 6 months after you lose capacity. So people that have dementia will potentially be unable to access this. You can have dementia and potentially still have early stage dementia. You still could have the capacity to request medical aid in dying. So people with dementia are not precluded from this law, but then they need to also have documentation that they're going to pass away within 6 months. And that's really where the key problem is with people with dementia. So it's another group that potentially will have difficulty accessing medical aid in dying as it's going to be implemented in New York.
Does the bill spell out how the use of medical aid in dying will be tracked or monitored?
I just went through it, and it's another really good question. Governor Hochul had indicated that Department of Health would be issuing regulations, so that would be an interesting thing for them to do, is to maybe start tracking it. Some other states, in particular Oregon, have very detailed statistics about who's using it, when they use it, increases, how it's being used from year to year. The law doesn't require it, but it would not surprise me if that became a requirement as part of state regulation.
Well, Mr. McArdle, I appreciate you making time to tell us about this law. This is very detailed and useful information. Thank you.
Oh, you're welcome.
My guest has been Edward McArdle from Upstate's Center for Bioethics and Humanities. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.